بسم الله الرحمن الرحيم. السلام عليكم ورحمة الله وبركاته، والصلاة والسلام على سيدنا وحبيبنا ومعلمنا وقدوتنا محمد صلى الله عليه وسلم. اليوم إن شاء الله هنتكلم عن موضوع مهم جدا في المرضى الغسيل البروتوني، وهو عموما البروتونيتس أو BD peritonitis, and we'll give you our experience in this topic of peritoneal dialysis patient. If you don't know anything in peritoneal dialysis, you should know this lecture today. You should listen to this lecture today at least to deal with any peritoneal dialysis patient with infection. I will cover all type of infection will come to you, to your clinic or your consult or emerge with peritonitis or exit site infection or tunnel infection. وإن شاء الله نغطي كل الموضوعات بالتفصيل، وفقط نسألكم الدعاء بالصحة والعافية والستر ونتوكل على الله. بسم الله الرحمن الرحيم. قالوا سبحانك لا علم لنا إلا ما علمتنا إنك أنت العليم الحكيم. صدق الله العظيم. بسم الله الرحمن الرحيم. وقل اعملوا فسيرى الله عملكم ورسوله والمؤمنون. صدق الله العظيم. ونبدأ بالصلاة والسلام على حبيبنا ومعلمنا وقدوتنا محمد صلى الله عليه وسلم. You don't forget this slide. I like this slide. You can't improve what you don't know, what you don't understand. If you don't understand what is how you can deal with the peritoneal dialysis patient or prescription, or what is you deal with the complication of peritoneal dialysis, you will not improve your program or your management for your patient. Well, I hope after all my presentation in the peritoneal dialysis, I will cover all topics in clinical practice. I am a clinical, not just educational. I give you how when you are in front of the patient, how you can deal with the patient. اليوم إن شاء الله it is just we'll start by these two slides. What is the peritoneal dialysis advantage per? Just we need you to know why the patient. I will advise the patient to go to do peritoneal dialysis. Why the patient to choose peritoneal dialysis is a better quality of life compared to in-center hemodialysis. We saw already in our clinics all peritoneal dialysis patient is doing perfect. Yeah, you know, he's doing clinical quality of life as regard his appetite, sleep, energy. You will find big difference between the hemodialysis patient and the peritoneal dialysis. I think it's because the peritoneal dialysis, daily dialysis, sustained control of his electrolytes and uremic toxins in comparison, and ultrafiltration and hemodynamic stability during the dialysis in comparison to hemodialysis, up down each hemodialysis. Daily dialysis is the one issue at home because the patient already socially between his families and can he attend his activities and parties like that. At home, no need to visit the hospital 3 times a week, especially if this COVID era. And patient autonomy, البيشنت خلاص بيتكيف مع الغسيل البروتوني ويبقى مبسوط معاه. بيتر ريزيدوال رينال فانكشن. انت عارف ان العيان بتاع الهيمودايليسيس دايما بيحصل له دروب للبلاد بريشر، وكل ده بيقلل على البرفيوجن بتاع الكدني، فبيحصل طبعا gradual loss of residual renal function. But in the peritoneal dialysis patient, you will continue steady state, no more hypotension during the dialysis, and the steady state of ultrafiltration. This will keep his residual renal function. We discussed already the residual renal function in the previous video in details, how this affect our survival and mortality. While the patient will not choose peritoneal dialysis or disadvantage, multiple steps, you know, and hemodialysis just will do just only will call intervention radiology or vascular to insert a line and put order for dialysis finish. But the peritoneal dialysis you need to discuss with the patient and the train and the PD catheter insertion or placement and the training more to the patient and the relative who is taking care or caregiver. And the peritoneal dialysis prescription, not all need to start gradually, incremental, small doses, and will increase as regard the fluid concentration according to volume assessment and amount of volume. Not all size fit all. Some patients tolerate 500, some 700, some 1 liter, 1.5 liter, 2 liter fill volume. كمية المحلول او الدياليزات اللي هتحطه في بطن العيان. تمام. Continuous glucose or dextrose loading, this may be good or bad, especially in patient uncontrolled diabetes. Also, limited technique survival in many centers. يعني مش كل المستشفيات او كل السناتر عندهم البروتوكولات والبروجرام for peritoneal dialysis. Our objective today to cover all infectious complications of peritoneal dialysis. الغرض من المحاضرة اليوم هنغطي إن شاء الله البروتونيتس أي الالتهاب الميكروبي أو الالتهاب عموما أي زر ميكروبي or maybe just a fungal infection in our patient. tunnel infection also ده المسار بتاع البروتونيال dialysis catheter through your abdomen. exit site infection already this مخرج القسطرة بتاعك على الجلد من برا على بطن العيان من برا ده exit site infection. هنتكلموا عن الثلاث اشياء دول اليوم بالتفصيل. We'll start by first case. Any case peritoneal dialysis came to emerge 30 years in this disease on CABD 11 years present to emerge for ER with history of abdominal pain. Any abdominal pain plus cloudy effluent for 1 day. Cloudy effluent means this is patient peritoneal BD peritonitis. Peritoneal peritonitis. But not all patients with don't think because the emerge doctor will refer direct. Any peritoneal dialysis came to emerge with abdominal pain, he will refer. Just rule surgical problem first. My main peritoneal dialysis generalized. His character is if he's being generalized and the patient will not look so good. But the other surgical problem, we have one female came by ovarian rupture and another male came by appendicitis, as another old male with atrial fibrillation came by ischemic colitis, and many differential cholelithiasis or cholecystitis. You should rule out surgical problem or hernial incarceration, especially umbilical hernia or inguinal hernia, and you can't return this inguinal hernia. This also you should search for this inguinal orifice. And if any umbilical hernia, don't forget incarceration of this inguinal hernia. Don't think all patients with abdominal pain came to emerge with peritoneal dialysis patient. You should rule out surgical first. Be sure your patient not surgical abdomen. Okay, the CT with IV contrast if you suspect any surgical problem. CT with IV contrast, whatever residual renal function or not residual function. Now, if you think this patient with query acute abdomen, please. Acute surgical abdomen, please do CT with contrast. Otherwise, also, and you will take peritoneal dialysis fluid for culture sensitivity and cell count like that, and differential. All this we'll discuss later, but don't miss any surgical patient. And I have one patient maybe 2 weeks back, just came by abdominal pain and the cloudy effluent, temperature 38. Direct, I give him antibiotic direct even before, just taking the bleeding fluid out for cell count differential and the culture, and give direct and the blood culture also I should take for that. If urine also, you should take urine culture and start your gram antibiotic to cover gram positive, gram negative, and we'll discuss this in details today. Did the picture nurse show you? Dr. Hamid, this our BD fluid effluent ده السائل اللي طالع من بطن العيان بعد الغسيل. تمام، هذا المنظر بتاعه ده كلاودي. شوف انت ما انت شايف، المفروض لو ده كلير هتشوف الاشكال اللي هي على السيراميك ده، هتشوف المفروض تشوفها من هنا، لكن عشان هو كلاودي فما هتقدر تشوف من ورا. هنا Icbd Guideline International Society of Peritoneal Dialysis Guidelines، انت هنا ممكن تقراها هنا في لو الافلانت كلير زي ما انت شايف كده، لكن مع الكلاود ده ما تقدر تشوف اللي ورا. ده اختبار ان انت تشوف الفلويد كلاودي او كلير الافلانت. ايه هي list of important questions to confirm diagnosis from history؟ انا عايز لما تروح تكشف العيان بتاخد منه history. ايه هي important question to confirm your diagnosis for BD peritonitis, any fever, any nausea, abdominal pain, all these criteria for to diagnose BD peritonitis. Changing color of the effluent from clear to cloudy, any discharge from exit site, you should ask and they will see any discharge in redness and inflammation on the exit site, any recent antibiotic or treatment allergy، يعني انت اخذت اي مضاد حيوي في الفتره اللي فاتت او اي علاج او اي الرجي للادويه ديت عشان تبقى عارف تحدد ايه بعد كده، عشان تشوف الانتيبيوتيك هل هو عنده الرجي للانتيبيوتيك ولا لا. change home or renovation، انت غيرت المكان بتاعك، المنزل بتاعك، او عملت تجديد للمنزل وكده. characteristics of the pain, what is the pain? Is this a surgical pain, localized pain surgical, or just a diffuse generalized abdominal pain with BD peritonitis. exit site skin color، بتشوف السكين color. compliance to hand hygiene، just ask the patient you are doing your hand hygiene and ask him steps for antiseptic before connection and disconnection of his machine. You have any previous peritonitis or treatment and the frequency and the number and what is the organism. You should check this with the patient and in your system or your chart or the patient chart. History diagnosis: fever 38, abdominal pain, nausea, vomiting, change in the color. Change the color yellow, discharge from the exit site. You should ask for this and examine also for that. Cloudy effluent, what is the cause of this change in the color? Cloudy effluent, this because high fibrin from inflammation and the slow inflow or outflow. Any problem for inflow and outflow. Health just this to keep your mind broad. Intraluminal or technique problem. We should ask the patient in you have any breach or انت خربت التكنيك بتاعك وانت بتوصل مثلا شال الجلافز او ما عملش هاند هايجين او عمل بروبلم في الكونكشن او ديسكونكشن without septic technique. Intraluminal technique problem, touch technique, connection and disconnection, open close technique. هو عمل بريتش هنا، خرب التكنيك ان هو مثلا شال الجلافز ما غسلش ايده، عمل كونكشن وديسكونكشن من غير ما يكون عمل استرلايز هاند او واشنج هيز هاند. بريك ثرو تكنيك از منشن، لو دي مثلا عايز يروح يفتح الباب لحد او يروح الحمام او يروح المطبخ او وات ايفر، وعمل بسرعه كده فك عمل ديسكونكشن without gloves without hand hygiene. And periluminal exit site or tunnel infection, the periluminal, intraluminal, and the periluminal from exit site or tunnel. If both infected will end by peritonitis also. Hematogenous spread, any surgical or OR, any surgical procedures or dental or catheter, colonoscopy, cystoscopy, all this you should give prophylactic antibiotic. This hematogenous spread also. Any wet bed leak. انت اي مره كده قمت لقيت السرير مبلول او الفرش اللي على السرير مبلول, must give antibiotic. You can give for 2 days or to cover gram positive at least or gram negative if your patient already be previous gram negative organism. At least 5 to 7 days. We'll talk with this later. No exit site care program. ما عندوش اي exit site care program ولا dressing ولا antibiotic prophylaxis مبرسين or gentamicin. frequent shower technique. العين بيستحمى من غير ما يكون متبع الاساسيات بتاعت الشاورز وانه يكون مغطي مكان التيوب كويس. prophylactic antibiotic local use as we mentioned المبرسين or الجنتامايسين. history of trauma to exit site infection. حصل له trauma whatever type of trauma بدات تبقى infected, وهنشوف الكرايتيريا بتاعت الانفكتد exit site. previous history peritonitis عنده, تشوف التريتمنت بتاعه, هو خد ايه العلاج اللي خده, الكورس بتاعه, الاورجانيزم لازم تعرف الاورجانيزم ديت كل النقاط اللي بيحصل فيها. spread of oral infection either hematogenous, transcolonic, and from this disconnection or precursor disconnection and connection technique, all these sites of introduce infection to our patient. Physical examination, you like to look for ايه اللي هتشوفه في الجنرال اكزامينشن بتاع العيان لما تروح تشوف العيان بتاعك, العيان ده توكسيك ولا لا؟ لان لو العيان توكسيك وهيمودايناميك انستابل ممكن يحتاج اي سي يو, ممكن يحتاج اي في انتيبيوتيك لو العيان داخل في سيبتيك شوك والكلام ده. الفيتال ساين بتاعتك ستيبل ولا لا؟ العيان ده محتاج اي سي يو, محتاج لاين ريموفال, محتاج اجريسيف انتيبيوتيك اي في لايك ميروبينام اور ارتبينام وات ايفر. abdominal examination, local pain or diffuse tenderness. ده بتفرق معاك كتير. diffuse ده ممكن معانا مع البي دي بروتونايتس, but local pain may be surgical abdomen tunnel palpation and milking. بتحط ايديك على, بتشوف البالبيشن للتانل وبتعمل له ميلكينج على الاكزيت سايد, بتشوف هيطلع ديشارج ولا لا. تمام, دي لازم تذكرها معاك في الهيستوري بتاعك. exit site for pain, crust, discharge and color. Tender abdomen, rule out surgical abdomen. Please don't forget surgical abdomen in any patient with PD peritonitis or hernia. Just check all hernial orifice. This is the source, maybe carcinated hernia. Check transfer set clean or dirty. Transfer set كده في البروتين دياليسيس ده اللي بتشوفه في الكونكشن والديسكونكشن, بتشوفه كلين ولا ديرتي, والعين مغطيه, والهايجين عموما بتاعت العين ولا لا. التريتمنت هنتكلم عليها طبعا بعدين, بس ده سمري جاست كده للكلمتين اللي فاتوا. في اللوكال اكزيت سايت, just gram positive antibiotic only with the right dose according to GFR of your patient. If exit, we'll talk about this dose later. If exit and tunnel, just gram positive or gram negative according to culture or previous infection, but should be cover gram positive. If peritonitis, just will cover by gram positive cefazolin, for example, or vancomycin, and the gram negative tobramycin or gentamicin, and the result of the culture from the first from the first look of the patient. Don't wait after a nurse taking her BD effluent for cell count, differential, and culture. Start your antibiotic if you suspect peritonitis. Any delay, all this will end by disaster in your continuation of your peritoneal dialysis, and maybe you'll end by peritoneal dialysis failure, and the patient shifted to transfer to hemodialysis. If you suspect peritonitis, start antibiotic after you're taking all your culture, and start direct antibiotic, not delay. Antibiotic in last fill, as we know, at least 6 hours. I discussed this before. Antibiotic should be in last fill for 6 hours, and we will add heparin. If it is cloudy effluent like that, you should add heparin 1,000. Don't forget each liter, 1,000 unit each liter to prevent catheter block or malfunction. Okay. What is if the one case came with high potassium and overloaded already? You will do and you need rapid cycle also with peritonitis, everything with this patient. That's how you can deal with patient overloaded, hyperkalemia, and peritonitis. Just we'll use rapid cycle for him, as we mentioned before in the previous presentation or videos. And loading dose 500 in the first bag. أول bag هتحط فيها 500 ملغ whatever type cefazolin and ceftazidime if you will start. And the maintenance dose 125 mg in each bag, 125 each bag after that. For example, you will start 9 hours, 6 cycle to keep the therapeutic antibiotic. If no urgent frequency cycle, if the patient is stable, just 1 gram in a long dwell, whatever cefazolin, ceftazidime, both over 6 hours per day, daily. When to give systemic antibiotic? At this point, if the patient came vitally and generally in septic shock and need nootropic support or catheter blocked, only these two situations you can give IV antibiotic. Whatever all trials and studies, IV proteinuria not lower than IV in control BD peritonitis. But if your patient is septic shock or catheter malfunction or blocked, IP superior to IV in all trials and studies before. But only these two situations I can't give IV because I need IV rapidly. Least important preventing strategies you would apply to address the above issues. BD nurse, peritoneal dialysis nurse review, exit site care program. You should have in your unit exit site care program. And all this we will find in Icbd guidelines. You will find all this. If you like to put protocol in your unit, you'll find all this in Icbd. Exit site care program, and the nurse, you should head nurse and peritoneal dialysis nurse should know that, and you should have team for peritoneal dialysis in each hospital providing care for PD patient. And shower technique, you should learn your patient how you can do his shower, proper local antibiotic, prophylactic antibiotic, and like gentamicin or mupirocin, and no one superior to the other. And I think both I bring already one study to show the difference between mupirocin and gentamicin. In nasal carrier MRSA, you should screen for this MRSA and check follow up the protocol. If positive, your positive patient is positive for MRSA, please follow the protocol. Relationship between an infectious complication, colonization, exercise, very common. Start point from here, you should cover by local antibiotic as a prophylaxis. Infection of exit site will end by tunnel infection, will end by peritoneal infection, and loss of BD catheter plus technique failure. These are our steps to end by BD peritonitis. The peritonitis fluids that have come infected and not related to any secondary cause of peritonitis, bowel perforation or appendicitis or surgical abdomen. PD peritonitis requires 2 of the following 3 criteria to be filled. You need 2 criteria from these 3 to diagnose your. The first criteria, patient came by abdominal pain, generalized abdominal pain, nausea, vomiting, fever, the abdominal pain plus symptoms or signs of fever and nausea, vomiting, plus this abdominal pain. And this cloudy, this will confirm your diagnosis by cloudy effluent. Your nurse will told you, the peritoneal dialysis nurse will told you, doctor, this fluid not clear, and already you'll check with your result of your cell count and differential. Why differential? To rule out monocytes, because some patient with long staying BD fluid in their abdomen, or patient dry day and giving just fluid from long dry. After long dry, maybe only monocytes, high monocytes. Maybe white blood cells is high, but only monocytes. But we need to diagnose what white blood cells more than 150% neutrophil to diagnose this in the PD peritonitis and the positive dialysate culture or gram stain. These are the three. This is the common question for you: abdominal pain, cloudy, positive culture. And don't forget, with cloudy should be white blood cells more than 100 and should be more than 50 neutrophils, not monocytes. Monocytes is not PD peritonitis. Over here, 2 of 3 clinical feature of abdominal pain or cloudy dialysate effluent, dialysate white blood cell counts more than 100, 50% neutrophils, and positive culture. Again, 2 of 3 BD cell count more than 150% neutrophil. After dwell time to I think 2 hours or 4 hours if you have time, abdominal pain, positive culture. And this a new solution and this cloudy effluent, the picture. New solution you can read on the bottom what is reading here, and with normal effluent you can read the back reading, the bottom reading, and this cloudy you can read anything from the back. Okay, new solution, cloudy effluent and normal effluent. New solution, normal effluent, and this cloudy of PD peritonitis. Presentation, as I mentioned, fever, nausea, abdominal pain, vomiting, and the cloudy effluent like that. Differential diagnosis of cloudy effluent, meaning differential diagnosis. Maybe BD peritonitis number 1, culture positive infectious peritonitis number 1, infectious peritonitis with sterile culture, chemical peritonitis, calcium channel blockers, أول حاجة bacterial infection or culture positive infection peritonitis. Infectious peritonitis, sterile culture, chemical peritonitis, calcium channel blockers can do, eosinophilic venophilia or effluent can do, hemoproteineum can do, malignant serine, chylus effluent can do, specimen taken from dry abdomen. As I told you, if your abdomen long time dry and you will put 2-hour dwell, will come effluent like that, but all this monocytes. The symptoms came with a differential diagnosis of cloudy effluent, either culture positive peritonitis or infectious peritonitis, sterile culture, chemical, calcium, eosinophilia, hemoproteineum, malignancy, chylus, and specimen taken from dry abdomen. Don't forget, I repeat some point clinical trick to fix it in your mind. What is the differential diagnosis of peritonitis? اللي تحطه في دماغك to keep your mind broad in differential diagnosis of peritonitis. Constipation, yes. Pancreatitis, yes. ممكن يكون عنده امساك، ممكن يكون هو سبب البين، ممكن يكون pancreatitis, ischemic bowel, CT with contrast. If you suspect, if high suspicion, don't look for residual renal function. If it is life-threatening, cholecystitis, I think ultrasound can diagnose that, or Clostridium difficile. Always consider secondary cause in any patient to suspect PD peritonitis. Initial assessment, as we mentioned, clinical examination with particular attention to assess of abdomen for symptoms and signs of peritoneal inflammation, or check your abdomen. Peritoneal culture exercise, and you will take swab. Any order, any peritoneal dilatation of abdominal pain, you should take swab from his exercise and the culture and the gram stain. If any drain or pus milking along with the tunnel, if any discharge from the tunnel, you should send for swab culture and the gram stain. Rule out the process of incarcerated hernia. Incarcerated hernia is the most important and missed from all of us. Don't forget to examine your patient for orifice, hernial orifice to rule out incarcerated hernia. This history determines the root causes of treatment for breach in sterile technique. Assess if recent contamination of LPD fluid, assess recent bowel habit. Initial assessment also ask about contamination, any contamination by your unsterile hands, accidental disconnection, endoscopic or gynae or procedures or diarrhea or constipation. You know, sometimes it came by diarrhea, constipation. This you will suspect maybe the diverticulitis or colitis, and this is translocational BD peritonitis. Don't forget this to rule out CT abdominal contrast to rule out diverticulosis or diverticulitis. And if any patient with history, from the history, some patient will tell you I am connected and disconnected without gloves, without hand hygiene. You should suspect strep epidermidis or staph. We'll see now. We'll come now to all this patient. You should know from the history at least 50% you can diagnose what is the type of organism. If you know, if you're taking good history from a patient. To diagnose BD peritonitis, if a patient came to emerge and his dry abdomen, what you will do, you will ask the peritoneal dialysis nurse to put dialysate 2.5%. We are usually using 2.5%, 2 liter, and keeping the abdomen of the patient for 2 hours or 4 hours, and then take sample. But better, most of the center taking 2 hours and send the sample for this PD peritoneal dialysis fluid for cell count and the differential. This means white blood cell count and the differential, and the culture sensitivity, and the gram stain also. You will send all this. Maybe also you'll ask for fungal if you suspect this patient recurrent BD peritonitis. Okay, as we mentioned, all this already mentioned. And send us all workup, CBC, leukocytosis, anemia, and the platelet. Where is your patient? Differential also, electrolyte, hyperkalemia, acidosis, whatever. Creatinine, it's high or low from the baseline. This patient, because if it's high, maybe the patient not complies to dialysis, maybe loss of renal function. Urea also, how much urea, calcium, phosphate, protein, albumin, all this albumin for nutritional status. That's not BD fluids that have been left in the peritoneum for an extended period. لو انت سبت الفلويد ده لفتره طويله في بطن العيان، اللي هو الغسيل البريتوني ده، او السائل بتاع الغسيل البريتوني، او الدياليزيت، او الديانيل، او الدكستروز. If you left in the abdomen, if your patient long time may have an elevated cell count, but this will be largely monocytes. Take care. Monocytes, our criteria, white blood cells more than 100 and 50% neutrophil, not monocytes, and is not indicated for peritonitis. Okay. Similar cell count from shorter dwell may be falsely low and may require the time 2 hours. We need at least 2 hour dwell. In such cases, really on the presence of neutrophil cell count criteria to initiate empirical antibiotic as indicated below. As we mentioned, dialysate effluent should be obtained at least 2 to 4 hours for culture, cell count differential, and the gram stain. Confirmation white blood cells we need more than 100 and 50% neutrophil, okay, to confirm your peritoneal dialysis. Next step will order for antibiotics, gram positive, gram negative. Will come to this point. Order dialysis prescription, and including the target weight of the patient, regular prescription for him, and the antibiotic usually given intraperitoneal once daily for 6-hour dwell. And CBD prescription, we already discussed in all prescription last time, last presentation. If you like to go PD prescription, I put it in separate videos to be clear for each one. Remember that the 6-hour antibiotic dwell is a minimum and can be in place longer, maybe 8 hours, maybe 12 hours. Patient may require higher percent of dialysate bags, as a peritoneal inflammation may lead to more rapid glucose absorption and therefore less alpha filtration. Maybe need high concentration or equal extran also. Extranil is better. Order additional intraperitoneal. You should don't forget heparin 1000 per liter. Heparin 1000 unit per liter. Heparin 1000 unit per liter for cloudy effluent. Until the effluent will be clear, then maybe 500 unit per liter. BRNF fibrin is still present, and the potassium chloride insulin are required, but we are not using this only. We can use potassium chloride for oral, and the diet not enough. Order frequency for effluent daily, cell count we need daily. Don't forget send the peritoneal fluid daily for cell count differential culture sensitivity, and at least cell count differential daily to check your patient response for no to antibiotic. For patients who are receiving vancomycin, check vancomycin level at 48 or 72 hours post initial dose. We are given regularly in the peritoneal every 5 days, but at least after 3 days you can check the level and we'll see. Our level in some centers the maximum target 20 and lowest target 15, and other centers the maximum target 15, but already if a patient less than 10 his vancomycin level, if less than 10 I will give 1 gram. From 10 to 15 I will give 500. From 15 to 20 I will give 700 milligram, and we'll check the level maybe after 3 days also. Hold the phosphate, don't forget this point. Hold phosphate binder, calcium supplement if peritonitis severe due to constipation. ما تروح تدلعين ريناجيل ولا سفيبراليمير or calcium carbonate. All this should be on hold to avoid constipation, more complication. Order appropriate diet and all other medication. All other medication same. Intraperitoneal antibiotic unless severe
indicates hospital admission. Admission may be required for patient with severe pain. I can't send the patient home. Should be admitted. Who are frail or may lack support. Intractable nausea, vomiting, how you can send the patient home. Where concern exists regarding outpatient delivery and administration of IP antibiotic, should be admitted in hospital. Where some degree of doubt exists over the diagnosis, concern regarding other source of abdominal pain, maybe surgical abdomen, and nothing clear till now, just admit the patient. If no decrease in cell count by day 5 or count fill initially and then increased, repeat culture and consider inappropriate antibiotic for organism. If no decrease in cell count after 5 days, associated exit site and tunnel infection may be the source of providing more organism you are treating down, and the source is giving you more from exit site and tunnel custom. Secondary peritonitis, especially ischemic bowel, cholecystitis, diverticulitis, appendicitis, pancreatitis. Don't forget this acute surgical problem. Secondary peritonitis, ischemic bowel, especially in elderly atrial fibrillation, came by severe abdominal pain. Especially elderly male, whatever, or female with atrial fibrillation or ischemic heart disease or peripheral vascular disease, and he came by severe abdominal pain, 10/10. And cholecystitis, by examination you can suspect that, and diverticulitis, diarrhea, abdominal pain, left lower quadrant, appendicitis, right lower quadrant, pancreatitis, central abdomen, refer to back, and severe pain also you should rule out. All this, if the patient needs CT contrast, go ahead. Don't look for a residual renal function if surgical abdomen. Management just to good hydration for your patient. To be sure your patient hydrated well, you can give him 250 normal saline or 500 normal saline, or a full protocol for CT contrast or contrast-induced nephropathy. You can follow the same protocol if the patient can tolerate. And keep your patient continuous in peritoneal dialysis during the CT contrast. I think this will be better for him to try to at least to predict as you can from his residual renal function. If the patient anuric, don't mind, go ahead and do CT contrast. Management of unresolving peritonitis after 5 days of appropriate antibiotic if catheter removal. If the patient refractory after 5 days, no improvement in his white cell count or neutrophils, just remove the catheter. And frequency of organisms is from Handbook of Dialysis, 5th edition. Frequency of organism isolated in patient with peritonitis. Gram-positive organism around 40 to 50%. The most common is gram-positive organism. Staph aureus, coagulase negative staph. CNS, coagulase negative staph, and Staph aureus. Staph aureus, the most common organism is gram-positive. Then you should, any infection should cover first, the most important one to cover gram-positive. Staph aureus, coagulase negative staph. And the gram-negative organisms, two bad organisms, Pseudomonas, this is very bad, and the Escherichia coli. The gram-negative organism, fungi, this is the third one. This is the third, 3 common gram-positive, gram-negative fungi. Mycobacterium at the end, polymicrobial, that's mixed, culture negative, around 15%. Identification of bacteria and route of administration. Just if you ask your patient, he is not drying hand and he's not washing the hand, not wearing his gloves. This with the staph, coagulase, aureus, maybe Pseudomonas, other negative. From the colon, patient with diarrhea and the left lower abdominal pain, using Enterococcus, bacteroids, multiple organisms, and yeast. And you should, if you will ask the patient in details all this, you can suspect this organism. Your patient here or here, and when you ask the history from patient, I diagnose one patient staph already. From that, the patient told you he's not following the protocol of hand hygiene. Other patient came by abdominal pain, diarrhea, left lower quadrant with frequent diarrhea. Just already the patient came Enterococcus, and CT showed diverticulosis, active diverticulosis at the time. Culture negative, consider all. This when you will send any patient came to emerge or readmit your patient as a PD peritonitis, don't forget ask for abdomen pelvis ultrasound to cholecystitis. Sometimes use expert, you can rule out appendicitis, and don't forget to ask for tunnel like tram track, like ترام تراك عامله زي موضوع سكه القطر. تمام، طريق القطر اهو، اي القطار او القطار. وهنا حصل عندنا هنا بريك هنا للموضوع. هنا ده الكوليكشن الموجود في التراك بتاع الكاستر. هنا ده تانل انفكشن. هنا المنطقه ده النورمال بتاعنا، ده النورمال تراك اللي بيشوف الالترا ساوند.
النورمال تراك اللي بتشوفه بتاع التانل لاين بتاع البي دي كاستر في الابدومن، في الابدومينال وول. هنا المنطقه ديت في هنا تانل لاين كولكشن، تمام. وادي الحجم بتاعنا مقسول، طبعا حجمه كبير جدا، فهنا تانل لاين انفكشن. بروتونايتس تريتمنت جايد لاينز. كان لنا زميل العزيز علينا من الصومال كان سأل على الجايد لاينز، بس انا فعلا ما معيش الجايد لاينز دي، بس انت لو عايز بتخش على الموقع ده وبيديك كل شيء بصراحه. Most recent guideline find them at www.icbd.org. تمام. International Society of Peritoneal Dialysis.org. Any guidelines you should take from this and put in your unit. Anything you need to be clear and you need to be fixed in your unit, just check this position, www.icbd.org. Okay, ISBD guidelines recommendation. If anything you need to know about the peritoneal dialysis protocols. Initial intervention at the BD nurse in presence of cloudy effluent with pain or fever. Consider 2 to 3 rapid cycle. النurse هتعمل لك 2 to 3 rapid cycle to relieve discomfort or abdominal pain. Initiate empirical antibiotic therapy with 1 hour while waiting for test result. Don't wait for a result. If cloudy effluent at the abdominal pain, start antibiotic. Start antibiotic. Don't delay. Delay is not good. In presence of very cloudy effluent or clot, you will add heparin, just 1,000 per liter, 1,000 not 500 to each liter, and initiate adequate pain management. All this protocol initiate. With regard to I mentioned for you, gram positive, gram negative, you should cover both. You should give cefazolin or ceftazidime if your patient was good urine output, or vancomycin, tobramycin, or we change the gram negative ceftazidime to tobramycin or gentamicin if no urine output. According to your local resident pattern, for some patient MRSA, you should use vancomycin from the start. We divide the initial therapy. When you suspect, you will give your patient antibiotic. What is according to urine output? If less than 100, more than 100 per 24 hours. Less than 100, I will give cefazolin and tobramycin. If no allergy, if beta-lactam allergy, we'll give vancomycin, tobramycin. Okay. If less than 100, less than means patient anuric, less than 100, cefazolin, tobramycin. Okay. And if allergic to cefazolin, beta-lactams, I will give a vancomycin and tobramycin. Okay. Or gentamicin, tobramycin or gentamicin, according to available in your center. If more than 100 per 24 hours, we'll give cefazolin, ceftazidime. This was good urine output. I will give cefazolin 1 gram, 1 gram. 1 gram, 1 gram, 1 gram and 1 milligram or 2 milligram per kg. And we'll come to these doses now. This daily, okay? And he the patient if sensitive to allergic to cefazolin, I will give cefazolin, I will give vancomycin, tobramycin. No allergy, if the patient less than 100 urine and uric, if less than 50, I will give 1 gram, one exchange, one cycle only per day. If less than 50 kilogram, I will give 1 gram cefazolin in 1 cycle per day for 6 hours dwell, okay, at least. Tobramycin 40 milligram in 1 exchange. 40, if less than 50, we'll give 40. Otherwise, we'll give 60. Okay, most of the patient will receive 60 milligram in 1 exchange over for 6 hours dwell. And if this cefazolin will be 1.5 gram in 1 cycle per day. If the patient live more than 50 kilogram. If the patient was good urine output, I will use cefazolin, ceftazidime. Okay, cefazolin less than 50 kilograms, I will give 1 gram in 1 cycle for 6 hours. Ceftazidime for gram negative, this is gram positive, gram negative. Gram negative, 1 gram, also ceftazidime for 6 hours. If the patient more than 50 kilogram, 1.5 gram, 1.5 gram cefazolin, ceftazidime for in dwell time 6 hours. Beta-lactam allergy, we are will give vancomycin, I will replace cefazolin. If your patient allergy, will replace cefazolin to vancomycin 30 milligram per kg, okay? And we'll give in 1 exchange we are giving every 5 days, okay? In 1 exchange for 6 hours, I think vancomycin can extend maybe 8 hours like that. 30 milligram per kg, because you are given only every 5 days in peritoneal dialysis patient, not like hemodialysis. Monitor the vanco level every 3 days and repeat down when the level less than 15. You should give at least 500. If less than 15, you can give 750 and we'll follow every 3 days the vancomycin level. And follow a dosing guideline for tobramycin as before, okay? Tobramycin 40 or 60, if less than 50 or more than 50.
If presentation of peritonitis is within 4 weeks of the previous episode, ensure antibiotic coverage address previous organism antibiotic susceptibility. Depending on the culture, treat should based on the micro culture sensitivity اللي حصلت قبل كده. Commonly useful organism are listed below. We'll see now all these types. If your patient grow enterococci, what you will do? Ampicillin, this is another guidelines, Icbd Guidelines. Ampicillin 125 milligram per liter in each exchange for 21 days. 21 days. Enterococci 3 weeks. 21 days. Ampicillin 125 milligram per liter in each cycle. This may require conversion to CBD for EBD for some patients. Some patients need better to put CBD because you can control that well better than CBD. If you revert a high level of gentamicin sensitivity and urine output less than 100, consider adding gentamicin 2 milligram per kg IV every 48 hours for severe cases. When you are given vancomycin, you are given this dose and we'll check the level. If less than 2, we'll give. Otherwise, less than 2, okay? If otherwise 2 or above, just will watch only. This also better to check the level before each dose, okay? Check gentamicin through the prior 2/3 dose. Should be less than 1 microgram. Prior the third dose, if the patient less than 1, I will give the same dose again. If some centers more than 1.5, but our target maximum 2 microgram per ml. Ampicillin and gentamicin cannot be mixed in the same bag. Don't forget this. Ampicillin, this chemical incompatible already. Ampicillin and gentamicin. Don't give in same bag. Maybe give one bag ampicillin and another bag gentamicin. Okay. If resistant to ampicillin, use vancomycin 30. Vancomycin الدوز بتاعتنا كام؟ 30 ملغ per kg every 5 days, and we'll give in future according to vancomycin level. Okay. Staph aureus organism. If the patient not allergic or patient allergic. If the patient MSSA bacteremia, methicillin sensitive Staph aureus. If no allergy, we'll continue cefazolin 2 gram or 1 gram daily. 2 gram in hemodialysis. Each hemodialysis. If patient hemodialysis and Staph aureus, will give 2 gram after each hemodialysis. But in proteinase, we'll give 1 gram daily. And if patient sensitive to cefazolin, we'll give vancomycin 30 milligram per kg, and we'll repeat it after 5 days or according to level after 3 days. MRCA, methicillin resistant Staph aureus. If the patient not allergic, vancomycin. Even MRCA, vancomycin, whatever allergic or not allergic. As we mentioned, methicillin sensitive Staph aureus, cefazolin according to the previous dosing for 21 days. 21 days. Staph aureus will treat for 21 days for severe peritonitis. We'll either add rifampicin also. If the patient has bacteremia, put in your mind to add rifampicin if slow response by white blood cell counts and it reveal daily follow-up. Just add rifampicin 300 milligram PID for 1 week, maximum 600 daily. 1 week to add this rifampicin. If there is an associated Staph aureus exit site or tunnel infection, BD caster should be put in your mind, should be removed. Should be removed if associated with exit site and tunnel infection. MRCA replaces cefazolin and vancomycin with 30 milligram per kg. MRCA will replace cefazolin to vancomycin 30 milligram per kg, around up to near is 500, whatever, and repeated dose every 5 days. Monitor every 3 days. The mentioned level before. Coagulase negative Staph the most common. Also, treat with cefazolin for 14 days. Coagulase negative Staph just only 14 days. If just a resistance also to methicillin resistance, just use vancomycin as before as a protocol. Single gram negative, ceftazidime. If any gram negative, ceftazidime 1 gram. If less than 50 kilogram, 1.5 or more than 50 kilogram in 1 cycle daily, and each dwell time 6 hours at least for 21 days. Gram negative, 3 weeks. Gram negative, dangerous than gram positive. You will give for 3 weeks, 21 days. If the patient allergic to ceftazidime, we'll use tobramycin 40 or 60 according to the body weight for 21 days. Plus, I prefer any gram negative, especially Pseudomonas, ciprofloxacin 500. I think once daily, but in hemodialysis, but I think in the BD we can use PID for 21 days. Okay, ciprofloxacin 500 BID for 21 days also with ceftazidime or tobramycin. you should use 2 antibiotics, okay? Multiple gram-negative and plus or minus anaerobe, ampicillin, ceftazidime, and metronidazole for 21 days. Multiple gram-negative plus or minus anaerobes. For these anaerobes, we'll use ampicillin and metronidazole. Metronidazole 500 BID. Dose of metronidazole for hemodialysis 500 BID for 21 days. Plus ampicillin as the previous dose and ceftazidime as previous. We'll continue all this if you're multiple gram-negative for 21 days. Rule out perforated viscous may be require imaging CT with IV contrast. If this appear multiple gram-negative, you should rule out any perforated viscous, especially if your patient is Crohn's disease, ulcerative colitis, diverticulitis, you should do CT with contrast to rule out if this organism came in your culture, okay? And covered by all ampicillin, ceftazidime, this gram-positive, gram-negative, and anaerobe. Pseudomonas is bad organism. Just combine anti-Pseudomonas for 21 days, as we mentioned, ceftazidime and ciprofloxacin. Pseudomonas, as we mentioned, ceftazidime 1 gram 1.5, whatever, and ciprofloxacin also for 21 days. If there is an associated Pseudomonas exit site or tunnel infection, put in your mind to remove the catheter. And continue antibiotic after this gram-negative Pseudomonas for 2 weeks after catheter removal. Don't forget this clinical pearl. If you have Pseudomonas and already the exit and tunnel, the catheter should be out, and 2 weeks antibiotic after catheter removal. Pseudomonas infection, this is from slide from our post, Dr. Abdelhamid. This Pseudomonas infection, isolated Pseudomonas, exit site infection, just isolated, just a trial of serum. If exit site only, isolate Pseudomonas peritonitis, just if isolated only peritonitis, trial of serum. Pseudomonas with exit site like that, you should remove the catheter. If you have peritonitis with exit site also in our BD fluid with peritonitis, remove the BD catheter. If only exit site or isolated only peritonitis without exit site, just a trial of serum. I think that's clear now. When to remove and when to remove, when not to remove. Don't forget nystatin therapy. Nystatin therapy, the 500,000 unit per oral QID, slow, not swish. Some told slow swish, no problem, but better to slow. We are needed for the intestine, not for the mouse. Not used like a transplant we are using to protect the oral trash. But here we need this all nystatin, our aim, GIT, not the mouse only. Is given for all peritoneal dialysis patient with peritonitis receiving course of antibiotic, whatever type of antibiotic, continue for 1 week post cessation of antibiotic course, especially if long course. 1 week after. Fungal peritonitis, serious complication, account for 1 to 15%. This is our slide from our post, Dr. Abdelhamid. Account for 1 to 15% of peritonitis episode. Technique failure in many, more than 40%, 35% in our cohort successfully returned to peritoneal dialysis. Mortality rate around 5 to 53% frail patient. Very bad. Account 1 to 15% of peritonitis episode. Technique failure in many, and the mortality rate is high also in frail patient. This fungal peritonitis. What is the risk factor for fungal peritonitis? Frequent peritonitis. Now I'm بديله التهاب في البطن او الغسيل بريتوني متكرر. Antibiotic therapy, prolonged antibiotic therapy, immunosuppression. Your patient taking also immunosuppression, peritoneal, vaginal communication, all this risk factor. What is the mechanism of you are given nystatin or mechanism of this fungal peritonitis? Antibiotic therapy. When you are given antibiotic long course for your patient, fungal peritonitis, how this can develop. With the fungi here, with the yellow one, and this bacteria. We are giving antibiotic to eradicate this bacteria and with our normal flora. And this fungi here, with prolonged course of antibiotic, the antibiotic will kill you. Then you add antibiotic already to the dialysate, and this antibiotic will kill this bacteria, and this will enhance the fungal growth, and this will penetrate to the peritoneal cavity and will end by fungal peritonitis. Again, we have here the normal bacteria and this fungi. When you are given antibiotic, you will kill all this bacteria, give a chance to the fungi to grow here, and this will end by penetration from the blood vessel to the peritoneal cavity and will end by fungal peritonitis. Antifungal prophylaxis, as we mentioned, success rate of prophylaxis will depend on the baseline rate of fungal peritonitis. units with high rate of dissemination demonstrate a reduction of the fungal peritonitis rates with prophylactic antifungal therapy. Oral statin may be convenient but safe already, but it's safe, no side effect. After catheter removal, this is the most common question. After catheter removal for fungal peritonitis, then what? When will I start renal dialysis? Hemodialysis. Some center 2 months, other 3 months, but better at least 3 months. At least 3 months, shift your patient to bridge to hemodialysis for 3 months, and after that, you can assess your patient if the patient like to return back to peritoneal dialysis. Don't forget this is the clinical pearl IP intraperitoneal heparin 1000 units per liter. If your patient is still fluid until your effluent be clear, and the conversion to CBD to give a better chance to extend your dwell for antibiotic at least 6 hours, plus or minus bowel rest to hold in peritoneal dialysis with enteric peritonitis. If you suspect your patient enteric peritonitis, shift the patient to hemodialysis. If the patient early with good residual function, just observe him without dialysis. Plus or minus peritoneal lavage. That's ask your nurse to do 3 or 4 cycles rapidly to clear the effluent and decrease the abdominal discomfort. Patient retraining and home visit. Please retrain any patient with peritonitis. Each time you should retrain all patient, retrain until patient fix all the step in his mind. And root cause analysis. What is the cause of death? Feed the infection. What the patient not follow our recommendation, and fix this analysis. Some definition. What means by refractory? If more than 5 days not respond to antibiotic, more than 5 days. Relapsing peritonitis episode occurs within 4 weeks of completion of therapy. Within 4 weeks by same organism, same relapsing, same recurrent, only different organism. Episode within 4 weeks of completion of therapy with different organism. Repeat episode more than 4 weeks. Repeated more than 4 weeks with the same organism. Castor-related peritonitis in conjunction with excited tunnel with the same organism. This is castor-related peritonitis. Peritonitis in with exit and the tunnel line infection with same organism. What is the indication for BD castor removal? Fungal. First one, you should remove immediately and treat your patient, I think more than 2 weeks. For after removal, refractory peritonitis, you should remove the castor. Relapsing peritonitis, refractory with exit site and common infection, Pseudomonas staph aureus, should remove your castor. This is an absolute indication to remove the castor. Consider castor removal if not responding to therapy, mycobacterium peritonitis, and multiple enteric organisms. If not respond, just remove the castor. Do I need to remove the BD castor again? Fungal peritonitis, refractory peritonitis, relapsing peritonitis, refractory with exit site and tunnel castor, and the tunnel line infection, you should remove your castor. Castor removal can be also be considered, and just after trial of therapy, if you like, repeat peritonitis, mycobacterium, multiple enteric, Pseudomonas. If you have an exit site with tunnel, you should remove. Staph aureus, if exit site only, treat. Pseudomonas, exit site only, treat. Pseudomonas, BD peritonitis only without exit site, treat. If Pseudomonas with all, castor removal. Staph aureus, just remove. Staph aureus, just remove. Except if your patient have only this access for him. Some patient no other access, no other way. No more choice for you. You should continue to treat, and we'll see. If still patient is critical, septic shock like that, you should take out. Indication of BD castor removal, as we mentioned. Second, peritonitis, bowel perforation, and refractory treatment. Fungal peritonitis, refractory, as we mentioned. Semi-elective, relapsing, repeating. With exit site and tunnel line infection, may enteric, may in certain castor removal or insertion. This according to your expert already, but the most absolute indication for removal, this patient with fungal peritonitis, staph, Pseudomonas, especially with exit site and tunnel line infection, and the patient with multiple organism or mixed organism, enteric organisms with resistance to treatment, you should remove. In first management clinical pearl, don't wait until the BD next BD exchange to start right away after you send, just for this antibiotic. Rapid as you can. You should put in abdomen of your patient 1 gram cefazolin and ceftazidime if the patient is good urine output, or cefazolin tobramycin or gentamicin, whatever. You should put in your patient gram-positive and gram-negative antibiotic once you take the cloud effluent for BD cell count and the culture and everything. You should start antibiotic early as possible. Don't wait for cell count or culture like that. And after that, you can decide to continue or stop. Heparin, don't forget this heparin. You should any cloud effluent, heparin 1000 units per liter until the effluent clear. Allow antibiotic to dwell at least 6 hours, as we mentioned. You can use this as diet at night. And second pearl, just all patients with peritonitis should get nystatin 1000 or 5000, 100 or 500,000 unit. Just PO, swish and swallow, or swallow direct without swish for duration of treatment and post week, and will continue more 1 week after finish your course of treatment. Ecodextran is compatible with the vancomycin, cefazolin, ceftazidime if being given in the last phase. Protein permeability of water, glucose, protein typically increase during peritonitis. You will be fast membrane. A reduction of ultrafiltration is often seen. Also, this is balanced by patient often having decreased oral intake during this time. Recommend monitoring volume status during a peritonitis episode, looking for both hypo and hypervolemia depending on the patient. You know, during the peritonitis status, you more vascularization in your peritoneal wall, and your membrane status will be transformed already to high or rapid or leaky membrane transport. When you are putting this high concentration, you should use ecodextran or high concentration 2.5 or 4.25 if your patient is the lowest concentration, because all this will lose osmotic gradient and will lose ultrafiltration capacity, and maybe your patient will absorb most of the amount of dialysate and maybe will go to volume overload. Just you need careful volume assessment of your patient and change your prescription according to your volume assessment. So the management per when do I use vancomycin if allergic to cefazolin or MRCA already? This is the two, allergic or MRCA. Fourth pearl, if allergic to ceftazidime, give tobramycin as before, or gentamicin, whatever available. Fifth one, daily, don't forget to send the daily effluent for cell count differential. Check culture maybe every 2 days. Culture some center using culture sensitivity daily until first no growth, then after that every 4 days until 3 are no growth. Hold the calcium, iron, and other phosphate binder of peritonitis to avoid more severe constipation. I think the message clear. 6 clinical pearl, assess the response to therapy, daily BD cell count differential, if patient refractory or no. Narrow antibiotic tool culture result. If culture came gram positive, I will continue gram positive antibiotic only. If came gram negative, I will continue gram negative only. And root code analysis and resistance or refractory organism, you should consider alternate diagnosis, maybe other surgical problem. And this chart for culture and sensitivity follow-up. If no growth in 2-3 days, will just will continue, or just will continue cefazolin and discontinue any gram negative. With some recommendation. And if gram positive came, we'll continue cefazolin. If gram positive with MRCA, we'll continue vancomycin for this patient, maybe 2 gram or 1 gram every 5 days. And according to the body weight of your patient, and this 1 gram, 1.5 gram, 1 gram, 1.5 gram. This will continue for 2 weeks, and this will continue. This calculus negative will continue for 2 weeks, and this will continue if gram positive or MRCA will continue maybe 2 weeks also, or 3 weeks. This MRCA will continue 3 weeks, and this Staph is also 3 weeks. We'll continue with this cefazolin or vancomycin, whatever the patient allergic or no. And the gram positive here will continue vancomycin with MSSA bacteremia and sometimes using rifampicin, as I mentioned before. This all from Icbd guidelines. Enterococci and bacillin, as we mentioned, with vancomycin here, and metronidazole also can use. Strep gram positive, this continue for 2 weeks here, duration for each one. This 4 weeks and this 3 weeks. And then streptococci here, cefazolin. This table or guidelines, you should you can return back at any time when you have cultural safety and you forget what is the protocol, what is the regimen you can use. You should go back to Icbd guidelines. Gram-negative here, Escherichia coli, Klebsiella, they can use tobramycin or ceftazidime for 3 weeks in a gram-negative, as we mentioned before. Polymicrobial will cover by this tobramycin or ceftazidime, plus ampicillin or metronidazole. This for polymicrobial at least for 3 weeks, or here 4 weeks. Minimum treatment for 4 weeks, polymicrobial. Pseudomonas or Stenotrovomonas, this patient we can use, like you should use 2 antibiotics, tobramycin, 60 or 40 as a body weight, or ceftazidime, this for gram-negative. You should use plus ciprofloxacin. I will use one of this, ceftazidime or tobramycin plus ciprofloxacin, and this should continue for 4 weeks. Okay. Fungal infection, we'll use fluconazole, 200 milligram in 1 bag, with dwell time at least 8 hours, every 48 hours. Fluconazole, just remember this, fluconazole or itraconazole, 100 milligram every 12 hours, but I think that's good. Fluconazole, 200 milligram in 1 bag, IV, dwell time 8 hours. And we'll discontinue other antibiotics started before, and this will continue for 2 weeks if yeast or fungi. Mycobacterium, rifampicin, isoniazid, pyrazinamide, pyridoxine, rifampicin, as we mentioned, 600 daily, isoniazid 300 milligram daily in a dialysis patient. This is the dose of dialysis patient. Pyrazinamide 1.5 gram daily, pyridoxine 100 milligram daily. Pyridoxine is vitamin B6 to reduce this INH-induced neurotoxicity, and you should monitor liver function test. Okay. And you should consult ID for that point, and because need long course also. Yeah. All organism just in any antibiotic or any organism should cover your patient by this nystatin, 500,000 unit. Swallow QID every 6 hours for duration of peritonitis, plus 1 week after the finished course of peritonitis. Okay. Antibiotic with anti-pseudomonas, we are using all this antibiotic with pseudomonas, ceftazidime, piperacillin, and ciprofloxacin, CVB. All this can be used with pseudomonas. But for me, I am using ceftazidime and ciprofloxacin. Antibiotic with anti-stenotrovomonas, this using Septra, and sometimes tetracycline like that, sensitive also to this organism, Stenotrovomonas. Okay, with this loading dose and maintenance dose. Oral therapy for peritonitis based on the cultural sensitivity when oral antibiotic are given, consider holding all phosphate binder, calcium, and ammonium, iron, all this because they'll end up constipation. Ciprofloxacin, for example, cotrimoxazole, cefalexin, rifampicin, all this should hold the other medication. Refractory, as we mentioned, if no decrease in cell count for 3 days or 5 days maximum, and white cells increase, repeat the culture, consider possibility of secondary, should rule out secondary, should do CT with contrast, CT abdomen with contrast, or ischemic bowels, colitis, diverticulitis, appendicitis. Refractory peritonitis defined as failure to respond to appropriate antibiotic within 5 days, consider temporary discontinuation of LPD, arrange for temporary hemodialysis, consider conversion of intermittent peritoneal dialysis or hoarding of LPD for at least 48 hours. If suspected microperforation of the bowel, intermittent peritoneal dialysis allow bowel to rest between treatment. Catheter removal is required for virtually all fungal peritonitis and serous refractory bacterial peritonitis. If you have filtration failure with peritonitis, just assess your volume of the patient and just change your prescription to short well with hypertonic fluid or dextrine or extranil. A more frequent exchange intermittent peritoneal dialysis. Note that ecdextrine is compatible with antibiotic. You can put antibiotic with ecdextrine also. The rarest syndrome, toxic shock syndrome in peritoneal dialysis, a rarely occurring phenomenon of toxic shock syndrome, has been reported in peritoneal dialysis patients with peritonitis, usually caused by toxigenic Staph aureus. Toxigenic Staph aureus. The criteria for toxigenic Staph syndrome diagnosis include fever, hypotension, peripheral vasodilation, picture of septic shock, very bad organism. Fever, hypotension, peripheral vasodilation. Indeed, differential diagnosis of severe hypotension and peritoneal patient with peritonitis should put this TSS in your differential diagnosis. Any patient with hypotension, in severe peritonitis. Abdominal catastrophe such as viscous or bowel perforation or Staph aureus associated toxic shock syndrome. Okay, with the differential diagnosis, any hypotension with severe peritonitis, just about abdominal perforation and the toxic shock syndrome. Don't forget cyst syndrome, any patient with septic shock, perforation, or toxic shock syndrome. Treatment includes broad spectrum antibiotic for this patient and directed and peritoneal lavage. If this patient came like that, I will start with Tazol, Marabinum, whatever, IV for this any patient with septic shock. And the peritoneal lavage carried out by short dwell, less than 30 minutes, ABD or IBD, whatever, short dwell cycles. The lavage should be carried out for at least 12 hours. The purpose of the lavage is to remove the toxin that is causing the toxic shock syndrome. Adequate coverage for Staph aureus should be ensured even if the culture are still pending. Start covering for Staph if in patient in septic shock. And now we are just a little, just to give a hint for peritonitis, we'll go to exit site and tunnel. We have another case, second case, 62 years, male patient, CEPD, presented to CEPD and presented by redness, pain, and discharge from the exit site. Redness, pain, discharge from exit site for 3 days. What's your diagnosis? And with the picture, discharge and a little bit redness and the pain at the exit site. This is a picture of exit site infection. With the picture of exit site infection with discharge, you will take a swab culture from this and send for culture sensitivity and the gram stains. I will take this for culture sensitivity, gram stain, fungal, whatever you like. And we'll clean this and we'll put a mubricine or gentamicin ointment. Exit site infection, tunnel infection, this purulent discharge from the exit site that indicate presence of infection. Erythema may or may not represent infection. Positive culture and normal appropriate indicative of colonization rather than infection. And this tunnel infection usually occurs in the presence of exit site infection, but rarely occurs alone. Pain while palpation the tunnel, you will go to tunnel and palpate, and you will do milking to tunnel to exit site will give you more discharge. This means exit site and tunnel infection. Exit site and tunnel infection, most serious and common exit site pathogens leading to peritonitis with two organisms, Staph and Pseudomonas. Staph aureus, Pseudomonas aeruginosa. Other organisms coagulase negative Staph species and the Divertilosis, Streptococcus, and other mycobacterium fungi. All this can do, but the most common two is Staph aureus and Pseudomonas aeruginosa. What is the feature? Exit site infection in purulence, discharge as we see, and the plus or minus erythema. Tunnel infection, erythema, edema, induration, tenderness over the subcutaneous pathway. Exit site and tunnel infection, exit site infection, you'll find maybe erythema, some maybe plus or minus zero purulent drainage, culture pass, not swab, culture from a pass, not only swab scan. May need to make hard to get this discharge to take culture. Diagnosis of tunnel infection, edema and tenderness along the castor tunnel. If you will palpate, you will find the edematous and the tenderness, plus or minus. You need ultrasound picture as I showed you in previous slide how to see tunnel collection and infection. Most likely organism Staph aureus or Pseudomonas. Need sometimes oral or IV antibiotic, and if no, peritonitis, consider castor revision. A revision for another new exit site in clean skin. Castor removal if a patient develops peritonitis with the same organism, refractory exit site or tunnel refractory, you should remove the line. When the patient develops peritonitis with the same organism. Some question you should ask your patient: any nausea, from vomiting, fever, abdominal pain, change in the color of the effluent, any discharge from the exit site, any recent antibiotic treatment or allergy to antibiotic to guide you for management, any change in home or renovation, any characters of the pain, exit site or skin color. Same question will ask. Compliance with hand hygiene to ensure your patient follows the protocol for aseptic technique. And technique problem, connection, disconnection, breakthrough technique, no exit care program training, shower technique following, prophylactic antibiotic local, history of trauma, symptoms of peritonitis, previous history of infection, how he treated, how long treatment, and what is the organism, history of allergy to antibiotic will affect the treatment. You should ask all patient all this. On physical exam, this typical picture of exit site infection, redness, crustation, inflammation. You should generally show vital sign, general examination for toxicity, and the color, redness, discharge, crust, color, red, discharge, crust from the exit site, abdominal examination for local diffuse tenderness along the tunnel line, and the tunnel palpation, milking for discharge. And you should look, feel, record any, look for an inspection for exit site, any signs of infection, and palpate for tenderness and the tunnel line and the milking like that, and record all this. And you should send it to culture. With all this education you will find with the nurse, this for nurse job, swelling, crust, redness, pain, and drainage. This in each visit. This is scoring for exit site monitoring. Each visit, the nurse will look for the swelling, crust, redness, pain, and the drainage, and they will put point for you. In each clinic, you should follow this protocol also if you like to put protocol. This is Icbd recommendation 2005. And you have already 2010 and 2016, but if you like to look, this was to check the new one, just check. And also you can here also swelling, crust, redness, same protocol. Just to let your nurse to put this in each patient, in each visit in our clinic. Initial management, just exit site infection, pathogens, microorganism, as I told you, staph and Pseudomonas is the most common organisms already. And we have other multiple organisms, gram-negative Pseudomonas, culture, negative fungal already. Tunnel infection, erythema, edema, tenderness along the subcutaneous pathway, but open ocal. Ultrasound, you can discover this also. Ultrasound tunnel catheter, almost always in conjunction with exit site infection, but rarely occurs alone. Staph aureus and Pseudomonas often cause this tunnel infection. How to manage exit site infection, culture and gram, stains, purulent drainage from the exit site, oral and or intraperitoneal antibiotic, adjust an antibiotic to culture and sensitivity, reevaluate. Infectious resolved, continue treatment for at least 2 weeks and reevaluate. If the infection are resolved for 3 weeks, consider catheter revision or remove. Revision means new exit site by new skin, via new skin area, and removal or insertion at another site. How to manage swab culture, sensitivity, gram stain, effluent also you should send for culture, cell count differential, and the gram stain, and ultrasound tunnel, don't forget that. If local site, exit site infection only, local and oral antibiotic, cefazolin with novoricin or gentamicin local. If we tunnel, just oral antibiotic, maybe you will cover gram positive, gram negative, right doses also. Treatment of exit site infection and tunnel infection. As we mentioned, mild infection, minimal erythema, no discharge, just clean twice per day, and with bovidine iodine, or typical chlorhexidine plus diluted hydrogen peroxide, gentamicin eye drops can also be used. If virulent discharge, oral ciprofloxacin, penicillin resistance, and the first generation cephalosporin or clindamycin also can be used, like cephaloxime or ciprofloxacin can be also used. Treatment of exit site and tunnel, just don't forget ultrasound for tunnel. Catheter removal should be considered when you consider catheter removal with exit site. If more than 3 weeks fail to respond to therapy, if Pseudomonas or Gonorrhea, consider early catheter removal. If peritonitis develop with the same organism, you should remove this catheter. If no clinical response, when to remove the catheter? If no clinical response, sepsis, septic shock, concomitant with peritonitis with exit site and the tunnel. Okay, no clinical response, the patient septic shock, you should remove the catheter. Continuous BD peritonitis with exit site and same organism with tunnel also, all this indication for removal. If more than 3 weeks antibiotic, this will precipitate fungal infection. Don't forget nystatin or fluconazole as a prophylaxis. BD exit site infection characterized by erythema, as we mentioned before, exit site plus or minus discharge, theropurulent discharge. Staph aureus is associated with Staph aureus nasal carriage, up to 50% of the exit site infection, associated tunnel infection. Oral or IP antibiotic resolve 50% of exit site infection. Consider catheter removal if the patient develop peritonitis with the same organism. Treatment local antiseptic, antibiotic, sheath, distal cuff. If protruding or reversible tunnel, better may require catheter removal or replacement. Treatment, empirical therapy always cover Staph aureus, MCC or MRC, and Pseudomonas if there is past history for that. And this dose is already for antibiotic to be covered exit site infection by ampicillin, amoxicillin. Just don't forget amoxicillin, clavulinate, 875 BID or cephalexin 500. I think cephalexin is better. BID twice daily, cephalexin 500. Or ciprofloxacin 500 daily or 250. I think this is the most common, and the other antifungal and everything you can read. I think if we can take picture for exit site infection, what is the antibiotic you can give if a patient had baseline culture before? Gentamicin or mebaricin in the catheter. This is the double-blind randomized control study already done to check who's the best, gentamicin or mebaricin. Creams, this is slide already by Dr. Abdelhamid already. You will see here gentamicin superior to mebaricin, yeah? Because it's on our poor countries already, and this shape already. Gentamicin superior to mebaricin in controlling the site infection. A regular application of antibiotic ointment to the catheter exit site, this to prevent exit site infection. You should follow this regular antibiotic regimen to exit site. This is associated with the reduction of exit site infection in some studies of peritonitis. Then the unknowns, the development of antibiotic resistance, effective ointment cream catheter integrity, and overgrowth of fungus. And that patient after gentamicin, some patient developed this fungal infection, as we see here in the previous slide. What is an important preventive strategy you would apply to address the above issues? BD nurse review, BD exit site care program, shower technique, proper prophylactic local antibiotic, nasal carrier MRSA screening, and the treat of positive. This you should your nurse review this exit site care program, shower technique, prophylactic local antibiotic, nasal carrier MRSA, check follow-up protocol if follow-up protocol for treatment of positive. Just looking after BD catheter exit site feature of health exit site clean. You should be exit site clean like this one, clean, dry, no redness, no scab or weep, no inflammation, no signs of inflammation. Okay, and this the best example for clean catheter, clean, dry, no redness, no scabs, no inflammation. And this is steps from the start of the colonization exit site if no prophylaxis local antibiotic until infected exit site, tunnel infection, peritoneal infection, and will end by catheter loss and technical failure. Definition of exit site is a good exit site by this criteria as we mentioned. Soiled will be soiled with redness, purulent, tenderness, inflammation. This is the criteria for both exit site. And if just for preoperative care, and we'll discuss this in next videos alone, how to prepare patient pre and during and the post-operative, what is our job of our nurse. Preoperative care, we'll discuss this in one presentation. All this will post-operative care, I have protocol also, I will present in separate videos, and the chronic daily dressing, what is shower technique and everything. And just I will tell you some preparation for surgery, prepare abdomen for surgery, whatever need shaving, showering like that, shows the exercise, avoid the skin creases when the patient sits, taking swabs and giving treatment, training the patient and their relative for good peritoneal technique, and regular exercise infection protocol follow-up. And this prevention of exit site care, we'll discuss this. Just don't forget antiseptic, antibacterial soap and water, hydrogen peroxide, and this will discuss reading preparation. This is gram-positive for cocci, two algorithm already for gram-positive cocci. This is based on cultural sensitivity. You will assess the clinical improvement, repeat dialysis, cell count differential. And the clinical improvement, coagulase negative staph just will continue. Clinical improvement here, coagulase negative staph for 14 days. And if staph aureus will continue for 21 days, enterococci 21 days, other strep, just staph aureus and enterococci for 21 days, other 14 days. If no clinical improvement and reculture and reevaluate, no clinical improvement, 5 days refractory and need catheter removal. This is a good diagram for gram-positive. And then the second diagram for gram-negative. continue gram-negative coverage based on sensitivity. Third or fourth generation cephalosporin, assess clinical improvement by daily cell count differential. If it's clinical improvement of Pseudomonas 21 to 28 days, 21 days is enough. Other gram-negative 21 days. Any other mixed gram-negative will continue 21 days. If no clinical improvement, castor removal. Gram-negative treatment duration at least 3 weeks. Gram-positive maybe 2 weeks to 3 weeks, except Staph aureus 3 weeks. But all gram-negative 3 weeks. Okay. Treatment duration. Just I summarized in this slide from Dr. Abd already. This slide just for coagulase negative staph for 2 weeks, Staph aureus 3 weeks, Streptococcus 2 weeks, sometimes 3 weeks, and non-Pseudomonas gram-negative, all gram-negative 3 weeks. All gram-negative Corynebacterium, whatever, 2 weeks. Only this Streptococcus and the coagulase negative only 2 weeks, and the other all 3 weeks. This terminology, recurrent, different organism, less than 4 weeks, recurrent. This to be easy for you with some terminology, castor-related peritonitis. This is peritonitis along with exit and tunnel infection with the same organism. With castor-related peritonitis, with recurrent, relapse, repeat, and don't forget this 4 recurrent, different organism, only is different organism, less than 4 weeks, relapse, same organism, less than 4 weeks, repeat, same organism, more than 4 weeks, refractory cloud effluent at 5 days, refractory to treatment. Again, same, relapsing, repeat, recurrent, refractory. Key factor about peritonitis, need urgent assessment and treatment. Culture fluid need to be done correctly. 2 hours of dwell time. Immediately start antibiotic. Don't wait for a result. After your patient taken, after your PD nurse send the PD effluent for culture. Assess whether you can manage at home or need the patient to be admission. Treatment continue at least 2 weeks. If the culture negative, antibiotic are changed according to what is growing. Continue gram-negative or gram-positive. Icbd peritonitis recommendation 2016, preferred intraperitoneal routes, aminoglycoside IP as an intermittent, avoid prolonged course, vancomycin IP intermittent, target more than 15, maximum 20, cephalosporin if IP either intermittent or continuous. Complication of IBD, tumor reduction, ultrafiltration because high transporter now, membrane characteristics, and increased protein loss, castor removal, adhesion, transfer to hemodialysis, and this is a complication of IBD peritonitis. Polymicrobial peritonitis gram-negative and some other some other organism. Possibility of intra-abdominal sepsis, hypotension, sepsis, lactic acidosis, elevated PD amylase. May need a surgical opinion. CT abdomen can be normal. Metronidazole IV or IP plus IV vancomycin and either IP aminoglycoside or IP ceftazidime. Treat for 3 weeks minimum. If laparotomy is in, consider the removal. Did the diagnosis already just to show you the incidence of coagulase negative staph and hospitalization, castor removal, and transfer. Hospitalization is, but the most common one is gram-negative. Gram-negative is a bad organism followed by Staph aureus. This is the most organism more than coagulase negative staph. In hospitalization, castor removal, and transfer to hemodialysis, the most common organism is Pseudomonas. This we'll discuss also. And yes, any patient with PD peritonitis, don't forget nystatin, heparin, and same daily cell count culture. This we discussed already before. Other peritonitis, fungal peritonitis. We discussed already this before, and TB peritonitis and the treatment. Don't forget all this. Risk factor for peritonitis, contamination, castor-related, Staph or Pseudomonas, bowel source, entry of organisms. This means all this risk for peritonitis. Bowel, especially patient with inflammatory bowel disease, bacteremia, and any procedures done, especially in gynecology, source of an Streptococcus and Candida. Empirical antibiotic as soon as possible after culture obtained. This already we told. If any patient came, just take the effluent for culture and start empirical antibiotic gram-positive, gram-negative. Icbd peritonitis recommendation 2017, as we mentioned, preferred IV antibiotic to IV antibiotic. And with all antibiotic, if you like to take a picture and you can read by doses,
And the theme also, systematic antibiotic dosing and recommendation for treatment of peritonitis. Conclusion of the clinical pearls today to cover all. We already cover all this. The most important clinical emergency subjects in BD patient, peritonitis, exit site infection, tunnel infection. As I mentioned, you should diagnose BD peritonitis by 2 of 3. Either BD cell count more than 100 or 50% of neutrophils with abdominal pain, or BD fluid effluent culture positive. You should have 2 of 3. Start antibiotic early as possible. After you send the effluent for culture sensitivity, just start gram positive and gram negative early as possible. Don't delay initiation for antibiotic gram positive, gram negative. Okay. And this duration of different antibiotic, I think all 3 weeks, except if strep or is negative, only 2 weeks. And the clinical, don't forget the heparin and change your patient CBD. Better to control the time because we need dwell time 6 hours, 8 hours. Maybe better to hold the BD if you suspect enteric peritonitis, and frequent lavage to decrease the pain, and the retraining and root cause analysis also. Just prevention of BD peritonitis, intensive training and retraining, training and connection, antibiotic prophylaxis for exercise. Wind contamination, you should give antibiotic prophylaxis. All this already we mentioned before. Indication for peritoneal dialysis retraining, prolonged hospitalization. Maybe patient will forget, and maybe will depend on a nurse at that time, and he will forget the steps how to do a complete aseptic technique for his BD at home. Peritonitis and catheter infection, you should retrain your patient. Here, prolonged hospitalization because the BD already nurse on call, she is doing all patient peritoneal dialysis because the patient is sick and no family beside him to support him. Peritonitis catheter infection means something wrong, you need retraining. You change dexterity or vision or mental acuity, you should retrain the patient. You change it to another supplier or different type of connection, you should retrain the patient. Agile interruption in BD, period of time on IHD, period of time in IHD, you should retrain your patient. Okay. Indication for removal, as we mentioned before, just if you suspect secondary peritonitis bowel perforation, you should remove the line and transfer patient to hemodialysis. Fungal peritonitis or refractory peritonitis, especially with staph. Fungal, refractory, relapsing, refractory, all this you should remove the catheter. Repeat mycobacterium, multi-enteric pseudomonas staph also you should remove, especially if with exit site and tunnel infection. Peritonitis, consider removal BD catheter if little number of refractory already, or fungal peritonitis. Don't let peritonitis drag on 4 days. Fungal peritonitis, stop antibiotics, fluconazole 200 IB every 48 hours. Catheter removal immediate. Continue antifungal for 14 days at least after catheter removal. After the catheter removal, 14 days. Prevention of exercise, the regular application of antibiotic ointment, either mupirocin or gentamicin. With cleaning if you're exercised by povidone iodine also. Appropriate catheter type and location may need 2 pieces of extended BD catheter, exercise care and septic solution, antibacterial soap or water, exercise ointment or cream, mupirocin or gentamicin. Don't forget hematogenous seeding is the source of BD peritonitis. Bacteria can cause peritoneal seeding and secondary peritonitis. Peritonitis hardly cause bacteremia. Don't forget this. Peritonitis rarely cause, rare to cause bacteremia, but the bacteremia can lead to peritonitis. Here, bacteremia can lead to, if the patient has septic shock and the bacteremia, blood culture positive can cause peritonitis. But the peritonitis, if the patient with BD peritonitis, rarely to cause bacteremia. Just put this in your mind. Hematogenous seeding from you should use antibiotic prophylaxis at time of any dental, as we mentioned before, antibiotic prophylaxis before our hemodialysis and the peritoneal dialysis patient, especially peritoneal dialysis patient, if dental work, even cleaning and endoscopy, our lower colonoscopy and genitourinary cystoscopy or gynecology procedures, whatever, you should use antibiotic prophylaxis to avoid this hematogenous seeding because bacteremia will end by BD peritonitis. For prevention, peritonitis training and retraining in all is all important from peritoneal dialysis catheter, exit site, antibiotic prophylaxis. From GI sources, prevent hypokalemia and constipation, from dental gynae procedures, also prophylactic antibiotic, monitor peritonitis rate closely.
And this our reference, and thank you for our post, Dr. Bargman, our mentor and peritoneal dialysis teacher. We learned a lot from her and Dr. Pearl and Dr. Malvadi Tushar and all our hemodialysis unit in UHN, San Michael and San Croix Hospital. Thanks to all, and this is our reference. And anything in the IBD, BD and general peritoneal dialysis, you should go to www.ispd.org and you'll check all guidelines and follow. If you need to review some management or some investigation or protocols, you should go to this site. ونسألكم الدعاء بالتوفيق والصحة والعافية والستر يا رب، ولا تنسوا دائما الصلاة والسلام على حبيبنا ومعلمنا وقدوتنا محمد صلى الله عليه وسلم. ونسألكم الدعاء بالتوفيق، ونلقاكم الله بفيديو قريب إن شاء الله. ولا تنسوا تشيروا الفيديو ده لزمايلنا كل زمايلنا المختصين في النفرولوجي أو الميديسن اللي مغطين النفرولوجي، على الأقل يكون عندك هنت أو عندك خلفية عن البي دي بروتونايتس، how you can deal, how you can manage. At least if patient came late night and no one to ask him to help you. وأتمنى دايما التوفيق للجميع، ونسألكم الدعاء بالتوفيق والسداد، ونلقاكم إن شاء الله بفيديو قريب إن شاء الله عن non-infectious complication peritoneal dialysis. ونستودعكم الله، والسلام عليكم ورحمة الله وبركاته.